Good afternoon, good morning, and good evening to wherever you are. We welcome you yet to another webinar series, which is a monthly webinar series organized by the Gambian Society for Microbiology. This is an association meant to improve microbial science and health science in the Gambia, and this is why we are all inclusive. Public health officers, healthcare givers, clinicians, microbiologists, pharmaceutical technicians, and all those working in the allied health sciences are all part of the association. Please do not do not be embezzled with the word microbiology. We are trying to bring a society, and we are affiliated with American Society for Microbiology, which is one of the biggest life science association in the whole world. We will not want to compete with Chinese with regards to the number, but I can tell you the impact of ASM is felt beyond all the 6 continents, including Africa. And to this, Gambian Society for Microbiology is also laying foundations in order to improve and, of course, mentor young scientists into the cohort of microbial science and its-related disciplines. Today, we have the president of Gambian Society for Microbiology coming up with a very fascinating topic to entice us. And who is the president of Gambian Society for Microbiology? Dr. Bah, also as the president of West African Postgraduate College of Medical Laboratory Science. Myself, I'm looking forward to become a fellow. She is also the chief scientist and researcher at the Edwards Francis Small Teaching Hospital, and of course, a lecturer at the University of the Gambia School of Medicine and Allied Health Sciences. So Dr. Bah is not actually a guest, but she's a pioneer and she holds a PhD in microbiology and is a fellow in medical microbiology with extensive expertise in infectious disease and public health. We will not be able to talk a lot or everything about what she does, but one thing that is very certain about her career perspective is her primary research interest that lies in human papillomavirus. If you will click on her name, HPV will actually surface. And of course, recently on antimicrobial resistance, which are critical areas that impact both clinical outcomes and public health policy. So Dr. Bah is my PI. Probably she's your president, but I see her as my PI. She led and contributed to several high-impact projects, including a successful implementation of antimicrobial stewardship program at the Edwards Francis Small Teaching Hospital. I think this is one of its, we didn't have anything like that. I mean, anyone working at Edwards Francis Small Teaching Hospital, excuse the slip of the tongue, we all come to know that we now have antibiogram, thanks to Dr. Bah and her team, which has become a model for the rational antibiotic use in the region, not only in the Gambia, but in the region. Her contributions extend to health policy and strategy planning, where she actively supports the Gambia Ministry of Health in crafting evidence-based frameworks to guide the sector. I think the ministry is lucky to have an expert. She has authored peer-reviewed publications with many people, including myself, and we have a lot under review and even have one preparation. She's always on top and has presented her research at both national and international conferences. That is actually furthering the global conversation she has on infectious disease and antimicrobial resistance. Since she's coming to entice antimicrobial resistance cases in our country, we will have to recognize her leadership, collaborative approach, and commitment to strengthen health systems through research, education, and policy. Dr. Bah, please take it all. Over.
Thank you very much, Dr. Bajenka. Good afternoon, good evening, good morning, wherever our people are. And like Dr. Bajenka said, my name is Dr. Haddy Bah. Today, I'm going to talk on antimicrobial resistance in the Gambia. The topic of the presentation is antimicrobial resistant AMR in the Gambia, a silent pandemic, and what are our shared responsibility. Okay, what is my slide doing? So this is going to be the outline of my presentation and introduction to look at the global context First, then I'll talk on the national situation and what were our findings in the AMR research in the Gambia and the implementation of antimicrobial stewardship, what we have done, what we have achieved, and what are the gaps, and what would be the recommendation and conclusion. Antimicrobial resistance, we all know this is a global public health challenge. In 2019, it was estimated that 4.9 million deaths were attributed to AMR. And the driving factors of AMR, two of the most known ones are antimicrobial overuse and misuse. And what can this lead to? Antimicrobial resistance can lead to an increase in mortality, morbidity, and health care cost. Because most simple procedures that could be done without problems these days with antimicrobial resistance has proven to be difficult. And if care is not taken, if we do not collectively work towards tackling antimicrobial resistance, it's going to cause a lot of problem in the very, very near future. WHO has put AMR as part of the 10 global public health threats. And in 2019, 1.2 million deaths as well. The greatest impact was seen in sub-Saharan Africa. In the same vein, it is projected that by 2050, we're going to record 10 million deaths annually. So looking at AMR burden in sub-Saharan Africa, $1.1 million deaths in 2019 was associated with antimicrobial resistance in sub-Saharan Africa, while 250,000 deaths were also reported in sub-Saharan Africa. Globally, AMR is a problem, but AMR is a huge problem in the sub-Saharan Africa. We see the burden very high in sub-Saharan Africa. So what are the factors contributing to AMR? We have the environmental factors, we have drug-related factors, we have patient-related and physician-related. I'll explain each of these. When we talk about the environmental factors, huge population overcrowding is one of the risk factors. People traveling, moving up and down, having one infectious diseases, which is resistant to some antimicrobials and spreading it around. Poor sanitation, this leads to community-acquired antimicrobial resistance. Ineffective IPC in our health facilities can also lead to antimicrobial resistance. The most common one, especially in Africa, is the widespread overuse or misuse of antibiotics in animal husbandry, agriculture, and medicated cleaning products. In the agriculture sector, antibiotics are given to animals. And if these animals have resistant microorganisms, in poultry farming, we use animal dungs as manure. So this can also increase the spread of antimicrobial resistance. Vegetables, if they're not properly washed, they can also lead to antimicrobial resistance. So when we talk about drug-related factors, we have fake drugs. We have drugs that are suboptimal. That means that they cannot treat or eliminate the microorganisms at a certain concentration because they're not at that particular concentration. We have those in pharmacies. The soaring use of antibiotics. Antibiotics, some illnesses might not be necessarily for antibiotics treatment. For instance, the common cold, which is a viral infection. Using antibiotics for the treatment of viral cold is useless. Over-the-counter availability of antimicrobials. Going into pharmacy without prescription, having easy access to antimicrobials is very, very common in most countries within Africa and the sub-region. Counterfeit and substandard drug causing suboptimal blood concentration. We all know that it's just going to knock the microorganisms, but it's not going to kill the microorganism. And this can also further increase antimicrobial resistance. We also have what we call the patient-related factors, which is poor adherence of dosage regimens, poverty. When we talk about poverty, for instance, if a patient is asked to get ceftriaxone and they get one dose in the morning, they're supposed to get one dose in the evening. If they cannot afford it, they miss the second dose. That can also lead to antimicrobial resistance. Self-medication. We all know that most of the time you get sick, instead of going to see a doctor, you just end up treating it yourself, especially the people working in the health sector. We are notorious. We do that all the time. And self-medication, sometimes we do have it right, but sometimes we don't. Because working in a health facilities does not make you an expert in everything, much more if you are not working within the health facility. Misconception and lack of education. Many people don't know what misuse and overuse of antimicrobial can lead to. They're not aware about antimicrobial resistance. We also have what we call the physician prescriber related factors. Most prescribers, they normally prescribe what we call empiric polyantimicrobial, meaning that they can, for one infection, they can give you 3 to 4 antibiotics, which may increase the chances of antimicrobial resistance. Overuse of antimicrobials and inadequate dosing. These are factors that we always see in our health facilities. Sometimes it is not necessary for a patient to have antimicrobials, but a physician will prescribe antimicrobials. Inadequate dosing, sometimes instead of 500 milligram, they will give 250 milligram. Or sometimes calculation might be wrong. So these are all factors that can lead to antimicrobial resistance. However, having said all of those, we also have what we call natural resistance, which can occur due to gene mutation, genetic mutation, and horizontal gene transfer. Some microorganisms can also produce enzymes, like the beta lactamase enzyme that is some organisms produce, and this help in um, making the antibiotics useless, not very, very effective. And others will have altered targets. They will also form biofilms, and that can also make the antimicrobial not very, very effective. So what are the consequences and impacts of antimicrobial resistance? We can have increased morbidity and mortality. Patients will die from simple procedures or having surgery and end up dying because they are infected with a multi-drug resistant organism. Increased morbidity or longer hospital stays and higher treatment costs, because the more you are admitted with multi-drug resistant organism or antimicrobial resistant, you stay longer in the hospital, and this tend to increase out-of-pocket expenses. Antimicrobial resistance also can cause reduce modern medicine or chemotherapy, because if you are infected with antimicrobial resistant organism, you will have a reduced immune system that can also lead to problem with treatment. So the challenges and gaps, we all know that antibiotics, we have limited new antibiotics. The rate that antimicrobial resistance is occurring, and compared to the number of new antibiotics that are developed, is very, very, very wide, the gap, because new antibiotics, they haven't developed new antibiotics for a long, long, long time. In most countries, regulation is a problem. We have a very weak regulatory system when it comes to antimicrobial use in majority of countries within the sub-region, including the Gambia. And we always have problem of access of antibiotic and overuse of antibiotics, because antibiotics or antimicrobials is easily accessible everywhere in every corner of the Gambia. Even without a prescription, you will get access to antimicrobial, which is a huge, 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 huge challenge. WHO, based on the summary that I've just given, WHO has come up with what we call AWARE. That meaning use accessible, the watch list that shouldn't be given all the time. And there are some antibiotics that are reserved. So that's how the name AWARE came up. Access An example of the antibiotics under the access are the ampicillins, which is the primary therapy. Then you have an example of the watch. You have the ceftriaxone. The reserve ones, you have the meropenem and the vancomycin. Now, coming to our country, the Gambia. In 2019, the global AMR distribution showed there were 1,800 deaths that were associated with AMR in the Gambia. The country was ranked 22nd highest with an age standardized mortality rate of 100,000 population, and this was across 204 countries. In the Western Sub-Saharan Africa, our country is the 9th highest age standardized mortality across 19 countries. So looking at this data, which was in 2019, this is a concern, knowing that our country is very small. If we are within the Western Sub-Saharan Africa 9th out of 19 countries, or 22nd out of 204 countries, this is a concern. Now, looking at the Gambia context, we have seen common available antibiotics that are showing resistance. When we started, we had limited data within the hospital sector. Infection due to multi-drug resistant pathogens, including the MRSA and the ESBL, this has been seen in patients in the hospitals and within the communities. And the high level of resistance also observed with penicillin and cotrimazole, which is commonly used in the Gambia. Cotrimazole is being used like prophylaxis. We had a study that we did. We went around talking to people in the outpatient, and we also went into the streets talking to people, trying to find out their knowledge of AMR. And when we asked about cotrimazole, Septrin, they know Septrin very well. And majority of these women in the market, they told us that they use Septrin when they are tired. At the end of the day, they go to the pharmacy. When they're really tired, they go to the pharmacy to get cotrimazole, Septrin to drink. And that helps them to relax. That is one of the things that we call misconception. Now, in 2024, we did a study at Edward Francis Small Teaching Hospital looking at antibiotic prescription practices and the awareness of the compliance at Edward Francis. This was a retrospective review. Why was this really necessary? Because in Edward Francis at the time, there was no AMR policy or guidelines which clinicians uses. So there was a need to assess the prescription habits and to formulate intervention to make sure that the right antibiotics is given at the right time, the right dosage, and the right route of administration. When we look at the prescriptions in Edward Francis for 2023 to 2024, we found out that most antibiotics that is prescribed is ceftriaxone, and 22% of the prescription lack a clear diagnosis. We also saw that antibiotics were prescribed for non-bacterial conditions like malaria, common cold, and fever, all of that. We also found that combination therapy of ampicillin and metronidazole, ceftriaxone and metronidazole was found highest in the A&E and surgical departments. Surgical prophylaxis with ceftriaxone constitute 47% of the antibiotics that were prescribed. Some people that had non-bacterial diseases such as chest pain, Cipro for malaria, ceftriaxone for chest pain, and all of this shows there was inadequate knowledge on AMR. And not only on Edward Francis Small Teaching Hospital, but in all other hospitals like Carnifing General Hospital. Antibiotic point prevalence study at KGM, Carnifing General Hospital, that was done in 2025. 14,898 prescriptions were reviewed in August 2025 month alone, and 69% were antimicrobials. Ceftriaxone was the most common antibiotic prescribed in Carnifing General Hospital. The same thing was also observed in Farafenni General Hospital, Soma, and Birkama. Ceftriaxone is the most abused antibiotic in this country. Now, lab surveillance. We also did some lab surveillance to see which of the microorganisms are resistant to most of these antibiotics that are being prescribed in our health facilities. We saw a significant level of extended spectrum beta-lactamase resistance amongst gram-negative isolates, E. coli, Klebsiella pneumoniae. At Edward Francis, this was at MRC. At Edward Francis Small Teaching Hospital also, similar findings were seen, ASBL, and ASBL resistant in amongst Klebsiella pneumoniae also in 2025. In 2024, which is the Pfizer research, AMR research study that we did, we also saw resistance across various isolates from inpatient at Edward Francis Small Teaching Hospital, from urine, wound, blood, tissue aspirates, and many samples that we've collected. And this data was a real-time data that we used to prepare the antibiotic prescription guideline for Edward Francis Small Teaching Hospital. The results showed that gram-negative organisms, majority of them were sensitive to meropenem, but half of these gram-negatives were resistant to ceftriaxone. The study also showed that ampicillin and the first and second and third generation cephalosporins, as well as the fluoroquinolones, were also effective against these organisms. At Bundung Maternal and Child Health Hospital, There was a neonatal sepsis outbreak in 2025. Samples were collected, sent to the lab, and the laboratory findings showed multi-drug resistant gram-negative organisms, Klebsiella pneumoniae and E. coli, were responsible for the neonatal sepsis outbreak in Bundung Maternal and Child Health Hospital. The same pattern was observed in Edward Francis Small Teaching Hospital in 2024, when we had the neonatal sepsis outbreak. In that outbreak, Klebsiella pneumoniae and E. coli were responsible. And the same pattern of resistance that was found at Edward Francis Small Teaching Hospital were also seen in Bundung Maternal and Child Hospital. The organisms were all resistant to ceftriaxone, the same pattern. This went further to tell us that we have a problem on our hands. If each of these hospitals continue to prescribe ceftriaxone, irrespective of laboratory diagnosis, laboratory confirmed diagnosis, majority of treatment is based on empirical treatment. An organism, which will cause patients out-of-pocket expenses. It will cost the hospitals. It will cost the state. Resistant needs collective and thorough Hello? Did my mic go? Badinka, can you hear me?
Yes, you are.
We can hear you.
Yes, you are.
You are doing very
Still
well.
audible, and we are really following, keenly following, looking at the trend. Yes.
Okay.
Go on, please.
The organisms were all resistant to ceftriaxone, both in Bundung Maternal and Child Health Hospital, and the same pattern was seen in Edward Francis. So as I was saying that antimicrobial resistance needs everybody to be on board if we want to tackle antimicrobial resistance in the Gambia. We need the IPC, we need the microbiologists, we need the clinicians, we need the nurses. We need everyone so that we can defeat antimicrobial resistance in our hospitals. Now, when we come to public knowledge on AMR in the Gambia, the knowledge of antimicrobial resistance in this country is very, very low. The study that we did shows that almost 70% of the patient and escorts, they haven't heard about antimicrobial resistance. 34 knew about antimicrobial resistance primarily through word of mouth, the social media. And 49 thought that antibiotics, they can treat cold, the common cold and diarrhea. So public attitude and practices, 38% said that they stopped taking antibiotics when they feel better, which shouldn't be the case. Once you start antimicrobial, you need to complete the dosage. Even if you're feeling better, you need to complete the dosage. 52% get their antimicrobials from private pharmacies without prescription, which is very common in the country. And this is something that the regulatory bodies need to look into this, that We shouldn't just be going to pharmacies and getting antimicrobials. Self-medication, over-the-counter availability, lack of public awareness and formal health education, inadequate diagnostics, separate and empirical prescribing, these are all problems that can lead to antimicrobial resistance. Stock out of first-line drugs, like for instance, the ampicillin, the penicillin, the first-line drugs. Also, first, some of the clinicians to resort to the second-line agents, such as the ceftriaxone. However, that shouldn't be the case because most of the ceftriaxones are being bought from outside pharmacies. So if there is no first-line drug in the pharmacy and maybe they have ceftriaxone, that doesn't mean that the clinician has to or the prescriber has to give the patient ceftriaxone. They can prescribe, let them go and get the first-line drug because leaving the first line, going to the second line can also cause antimicrobial resistance. So what are the role of the escorts? Because most of these escorts, they bring patients to the hospitals, they help in administering the antimicrobials at home. So educating these escorts on AMR is very, very important. And engaging in self-medication practices, if they are aware, they can help reduce the self-medication and influence patients to continue with their medication, not to stop it when they feel much better. So there is a need to raise awareness among experts, among patients, within our family, within our communities on antimicrobial resistance, because the awareness in the community is very, very low. So what are the gaps in national AMI response? We don't have a national antibiotic prescription guidelines, but Edward Francis Small has one that was developed. And we have weak antimicrobial stewardship programs across the country. Limited public health campaigns on AMR. We need to do more on AMR. And also there is very inadequate surveillance and reporting systems. So what are the strategies and intervention that we need to we need? We need antimicrobial stewardship program, effective infection prevention and control, improved diagnostic in terms of laboratory, and public education and awareness. So why do we need antimicrobial stewardship? It is very important because once hospitals or clinical facilities have antimicrobial stewardship, that will help the use of antimicrobials in a proper and appropriate manner. And that will lead to effective patient management resulting in very good patient outcome. Because at the end of the day, that is what we want. Using broad spectrum antibiotics triples patients' risk of infection. The antimicrobial prescription that is done in our hospitals need to be reduced, or else we'll continue to have antimicrobial resistance in the country. So antimicrobial stewardship program, we have instituted one in Edward Francis Small Teaching Hospital. Then we went to Carnifing General Hospital, Buyam, Bansang, and Farafenni. So these are all centers that have antimicrobial stewardship program. All of this is geared towards reducing antimicrobial resistance in the Gambia. But what is the finding of the antimicrobial stewardship programs that we have done? Patient treatments is still empirical. Most clinicians, they're not using the laboratory for to confirm. First-line therapy is being used. Unnecessary polyantimicrobial therapy is still ongoing. In most health facilities, the IPC is very poor in some hospitals. Environment decontamination is inadequate. Clinicians not using the treatment guidelines, and there is lack of program ownership. Lack of program ownership is what is killing the antimicrobial stewardship program. Hospitals should own antimicrobial stewardship program and put it as part of their management of antimicrobial resistance in their hospitals. But if they see it as a different program, it becomes a problem, and then the program is going to be dormant. So this is the problem, that the lack of program ownership is a huge problem in all of the hospitals that antimicrobial stewardship program is set up. This is one of our visit in one of the hospitals, whereby we went in there, patient admitted, sitting on the bed with escorts. You can see how comfortable the escorts are sitting on the bed of the patient. And we are talking about antimicrobial resistant, IPC, nosocomial infection. So this is something that we need to discourage from our hospitals, whereby escorts are allowed to sit on the patient bed and just there chatting with the patient sitting on the bed. So this is the antimicrobial stewardship team in Birkama District Hospital, where we went for ward rounds together with the National Antimicrobial Stewardship team. So precision medicine as a future strategy, we need to understand that not only culture, the standard microbiology culture and sensitivity that we need. We can do a lot with other methods in terms of antimicrobial resistance. We can have the genomics that can, the AI and genomics could tailor treatment in resource-limited settings. We can also have rapid diagnostics as the point of care test to reduce empirical prescribing. All of this is precision medicine which could be used in the very near future. Now, what are the recommendations that we made during all of this intervention that we took? There is a need to strengthen AMR surveillance in the Gambia, promote antimicrobial stewardship, and expand laboratory and diagnostic capacity. In our health settings, we'll end up having issues. We'll end up having antimicrobial resistance because there is no one is empirical therapy. There is a strong need to expand laboratory and diagnostic capacity in all the health facilities. It is very, very important to have a standardized, well-equipped microbiology laboratory in the diagnosis of infectious diseases. There is a need to raise public and professional awareness. There is a need to have community campaigns and training on AMR prevention. If we do not do this, if the community don't know the risk of self-medication, using antimicrobial as prophylaxis for tiredness, using antimicrobials in the poultry farm, we will be back to square one. And most importantly, it is important to enforce policy and regulate antibiotic sales, strengthen IPC in our health facilities. But most importantly, there should be funding to encourage people to continue working on antimicrobial resistance, finding solution to limit antimicrobial resistance in the country, or even to eliminate it from the country. So what are our shared responsibility in antimicrobial resistance, to tackle antimicrobial resistance? As healthcare providers, we should prescribe responsibly, educate patients. Not everything should be cured with antibiotics. No. Some diarrheas, they don't need antimicrobials. All they need is ORS and loss of fluid. Common cold doesn't need antibiotics. So these are things that people need to be aware of. Patients and families, we have responsibilities. We need to complete our doses of antimicrobials. We need to avoid self-medication. We need to stop treating ourselves or our families with antimicrobials when we don't know what the diagnosis of that particular family is. Policymakers, they need to regulate antibiotic use in the country. There's a strong need for the country to have regulation on antibiotics. You can just walk in a pharmacy without a prescription and they will sell you antibiotics. Even if you ask for vancomycin, which is in the reserve group of WHO, they will sell it to you without a prescription. There are some antimicrobials that shouldn't be given out without prescription, and we need to regulate this in our country. It is our shared responsibility to make sure that antibiotics or antimicrobials are only given when it is necessary and when it is requested. We also need to generate local evidence to monitor trends. And this needs funding. So the responsibility is not only on healthcare providers, patients and families, policymakers, but also on the government as well. Because the government, the policymakers up there, they need to have funding available for researchers to continue to generate local data to inform decision, which is very, very key in the drive to tackle antimicrobial resistance in the country. So in conclusion, AMR is a silent pandemic with severe local impact in the Gambia. Combating AMR requires shared responsibility and sustained commitment. We have responsibility to make sure that antibiotic, the ones that we are not saying resistant as of now, to safeguard those ones. We started seeing enterococcus, vancomycin resistant enterococcus. We also have started seeing antibiotics, microorganism resistance to ceftriaxone. We have also seen microorganisms that are also resistant to meropenem. though they're not many, but we have seen it in our study. So therefore, we have a responsibility as healthcare providers to safeguard the antibiotics that we have at the moment. On that note, I said thank you very much. Over to you, Bajinka.
Thank you. Thank you so very much, Dr. Haddy Bah, MRI champion, and of course, an advocate, a steward, and an expert. Well, I have been. I was not sitting while attending this webinar. I'm lying down, trying to scroll down slides. At certain points, I feel the need to cry. But at certain points, some points later, further on during the talk, I could see some remedification or perhaps a motivation in which we can spot on. Thank you so very much. And I believe the audience or the participants for this webinar keenly following, because if you go through the chat, you could see some very interesting comments and of course provoking some questions that we will have to go through to see. But before we go through the questions in the chat, I just want to say thank you. Thank you so much. This is a well presented, well articulated, informative, and of course up to the time that we are looking forward to. So I will say thank you once again, and thank you, Gassam. And then I will move this webinar to the next session, which is question and answer session. And means the floor is open for anyone to chip in or to raise hands, so you'll be given a platform so we can have a discussion before going to the chat. Over.
Yes, Dr. Bajinka. So,
Yes,
okay,
the chat.
Yes, I can see 2 hands have been raised. So we need to permit people that raise their hands to talk, because the default settings is that people are muted. But yes, okay, let me just allow people to talk. So there are 2 hands raised. I'm going to allow them to talk. I also have questions of my own. I'm going to ask after these people have asked their questions. Thank you. So
yes,
Ignatius, iPhone, and Alpha Diba. Yes, any of you can talk. You have been unmuted.
Hello. Good afternoon.
Yes, good afternoon, Ignatius.
Yes. Good afternoon, Dr. Bajinka. Thank you very much for allowing me to ask my question. And I just want to thank Dr. Haddy Bah for this brilliant presentation. Excellent work. And may this continue indeed. I'm really grateful. I have 2 questions. I actually posted one during her presentation, but I have 2 that I want to ask now. The first one is at the beginning of her presentation, she showed a slide where which had interactions between human and animals, in terms of AMR. But unfortunately, as it always happens, discussions on AMR mostly concentrate on human diseases, human health. So I just want to ask, what is the level of interaction between the 3 different sectors of health? That's animal, human, and plants. In terms of under the One Health concept, because you know that as he has rightly mentioned, this AMR problem is a cycle that goes through all the 3 different units. So if only one sector is capacitized or is concentrating and talking about it, and the others are dormant, then there's always a missing link. It will be very, very difficult to actually address the problem comprehensively. So I just want to know what is the level of interaction between these 3 groups. One. The second question is about doctors' empirical prescriptions. Is it because down to the fact that they are not comfortable with the quality of results that are coming from the labs? So they just decide to go ahead and give their own medication. In terms of what are the strengths of our microbiology diagnostic laboratories for providing quality antimicrobial sensitivity resistance patterns of our organisms. Yeah, those are the two questions I wanted to add to the one that I actually posted earlier. Thank you very much.
Thank you. Thank you, Ignatius Balde. I think it's Ignatius Balde, my former boss. Yes, it's good to have you here. It's good to have you here. Dr. Bah,
Yeah.
so which one do you want to start with, the first one or the second one?
Yeah.
You choose, please.
Yeah. Let me answer. Oh, thank you very much, my brother Ignatius. Good to have you here. To your first question regarding the One Health and based on the One Health approach to tackle AMR, we have what we call the AMR National Task Force, and we have people from the veterinary and the human side. So we're all working together, and we do have forums, a forum that we exchange, we have our discussions. So we're working together, and they are all part of the National AMR Task Force. Coming to your second question on empirical therapy, the microbiology laboratories across the country is not well strengthened. That is a fact. It's not. And based on that, most prescribers tend to do empirical therapy. However, when we come to Edward Francis, where you have the microbiology lab there, when we started the Pfizer research, we were receiving samples from the world, and that made a lot of difference because at least the treatment was targeted therapy. To answer your question, not all the microbiology laboratories within the country are strengthened, the ones that are established. They're not strengthened the way it should be. No. Sometimes resources are a constraint. I do understand why some prescribers keep on doing empirical therapy, because you request things and you might not get it. However, it is always good to check with the laboratory before empirical, to collect samples, send to the lab, and start your empirical. If the results come back to the lab and tells you ampicillin is resistant, use, let's say, Cipro, for instance, then you know what you're dealing with, and then you change to targeted therapy. So yes, resources is a huge problem, even at Edward Francis. The microbiology lab is not strengthened. The microbiology lab in other health facilities also are not strengthened. So there's a need to strengthen the microbiology laboratory. It's not about the results that is coming out from the lab, but whether the lab is able to perform that test up to the level of getting the results to the doctor to say, use this particular antibiotic. That's the problem. We have human resources, but we don't have majority of the materials that we need to work with. That's the bottom line. Thank you.
Thank you so much for that clarification, and of course, putting it straightforward to the fact that yes, we are still resource limited, and even the only country referral hospitals still struggle to come up with some of these antibiotic kits in order to show resistance, susceptibility, and testing. So if that happens to the main referral hospital, we can assume that, yes, our other hospitals, bigger hospitals still struggle. So that's well clarified. And thank you for that question. So we've noted that we are moving through time very fast than expected. And so we will expect questions to be written in text, in chat, Q&A session.
We have Al-Husseini hand up.
Yes, so we will take Al-Husseini and then we will be taking questions, reading questions out, so we save time. Al-Husseini, please.
Hello, could I please confirm my audibility?
Yes, we can hear you.
You are.
All right, thank you very much. First of all, I just want to thank Dr. Bah for this wonderful presentation. Actually, I want to comment, or I want to ask a question on the future strategies. Currently, I'm an MSc student at in India here at the Gujarat University. So we have seen in the, I'm sorry, maybe I may go out of the context perhaps because it's concerning the Gambia. I'm not sure if it is worldwide. So in the world here, we have seen people now using host-directed therapy in terms of AMR strategies, future strategy to combat AMR. What is your take on that? In a sense that they basically utilize the host's own immune system to actually inhibit the growth of these resistant organisms and try to control their growth. What effect will this have on the host in try to control these antimicrobial organisms?
Yes, Dr. Bah, so I think I can help to reframe the question.
I didn't hear most of what he said. He said he's in India, but
I know India, and not only in India, but in Gujarat.
Where?
It's good to have you. It's good to have you. Thank you for representing the people of India. We love you. And
thank you.
Yes, that question is very provocative. He's talking about precision antimicrobial resistance, precision therapy for antimicrobial resistance. Try to bring in
targeted using the
host immune system. That is to, yes, that is to say, going through the omics bioinformatics of the patient in order to depict what sort of resistance or vulnerability or targeted therapy the patient will go through. It's a new model. I hope so.
It's a new thing, and these are things that they're trying. It's not perfected yet. Al-Husseini, it's not perfected yet, and so that's like in the future, which could be done, whereby the host cells would be used, the genomic genomes of the patient that can be used in treating antimicrobial resistance. The technology is not perfected yet.
Okay.
We have to be mindful there. It's not perfected. It's not being used everywhere. It is a new technology that they're working on, but not yet perfected. So that's why I said this can be feature therapy to be used. However, for now, it is best to preserve what we have by tackling antimicrobial resistance as it is now, or else it's going to be a problem. The projection is not looking really good. And tackling it now can save us a lot of problem. However, the technology that you've just said, it's not perfected now. It is something that is evolving. And hopefully, if AMR is still a problem, that's the direction to go. That's the future therapeutic way that other countries are looking into.
Yes.
Yes. Dr. Bah.
Yeah.
Yes. I was going to say Lamarada will say something. Thank you.
Yes,
Please go ahead.
Yeah.
Yes, thank you so much for that answer. And I just want to chip in on Al-Husseini's question. So yes, I'm glad that he actually raised this, and you are very right to say it's an emerging area that people are exploring, but there has been a lot of advancements in the area, and I would just like to highlight that myself and Dr. Bajinga, we've written an article, is currently under review, on precisely this thing that Al-Husseini is talking about, on mechanisms of actually tackling AMR. And one of the aspects that we've highlighted is the prospects of using host-directed therapies as a potential way of tackling AMR. And I really believe that, if although in terms of omics technologies, the Gambia, we have a long way to go, but it's a very potent technology that is in the pipeline, and I believe our health practitioners should consider approaching the problem through that aspect as well. Even though we might not immediately adopt the technology, but it's on par that we would get to a stage where this would become a reality. So I just wanted to respond to this and also prime people to look out for the paper, as it would be very beneficial in with regards to the presentation that you have made here, considering the problem that AMR is posing currently in the Gambia. Thank you.
In the Gambia. Thank you.
Yes,
Doctor,
great things are coming up.
More questions?
Yes, of course, Doctor, we have more questions, but we're going to read some questions with summary so that you can answer them simultaneously. One says, what would be the driving factor? Of course, want to say, what will actually made the physicians to prescribe antibiotics for non-bacterial infection? For instance, during your talk, you talk about viral infection. Why will physicians do that? That's one question. We combine
lack of awareness.
Yes, that's good. We can bring a lot of factors that actually will be answered to the following question, which says that after all the findings we did for the antimicrobial stewardship program at Edwards Francis Multitude Hospital, one question is, it happens at the Edwards Francis Multitude Hospital only. Why? And then the follow-up question is, does it mean that the document will be kept at the front desk, or will it be shared with the healthcare providers or the ministry so that actual actions can be taken? So we can combine all these questions to you. Over.
Okay. The reason why prescribers are prescribing antibiotics for non-bacterial infections or illnesses and practices of physicians. Not physicians, prescribers. We found out that some have knowledge areas. So therefore, awareness, lack of knowledge, and training could be some of the factors. Now, the work that we have done in Edwards Francis, we did some very good work, if I may say, at Edwards Francis Multitude Hospital. The results were disseminated with the Ministry of Health, Edwards Francis, and other stakeholders, WHO, and our other health facilities. They came during the dissemination of the results. The antimicrobial guidelines that was prescribed for Edwards Francis Multitude Hospital was given to the hospital management, and it was distributed to the wards for them to be used. Because the picture in Edwards Francis Multitude Hospital is not different from what we saw in other hospitals in the Gambia. So we gave those hospitals the prescription guideline to use in their hospitals whilst they gather their data. So far what we have seen, there is no difference between what is seen in Edward Francis Small Teaching Hospital and other countries. Now, the question is whether Edward Francis Small Teaching Hospital or other hospitals are using the guidelines. That is the next stage that we are embarking on to do. That is evaluation on the use of the prescription guideline. So hopefully we'll have another webinar to discuss whether they are being used or they're gathering dust in their cupboards. Thank you.
Brilliant.
Badinka?
Yes, of course, I'm still here and I'm alive. So see, this is a collaboration. Dr. Prof. Tunkara, please step forward. I think this these triple questions needs some further. So luckily your core PI is here. Prof. Tunkara, please step forward. Yes, Prof.
Do you have another question?
Yes.
What's the other question?
Will you say this is a wake-up call to the institution of higher learning in the country to improve their curriculum in ensuring medical and allied health students to equip with adequate training before releasing them to the field, which is a very important question. That is to say, are we to include antimicrobial resistance as a module in our curriculum before we can see our physicians, doctors and nurses going to the patients? Over.
Yes, I think it is very important to have antimicrobial resistant. Under the microbiology, there should be a topic on antimicrobial resistant that is taught in the university. This is something that we discuss at the national level, like we have a national antimicrobial task force where we discuss this. If Dr. Haddy Bah is online, we were on this in the same team, and this is something that we discussed, and maybe hopefully it will be something that in the future we'll see in the higher education curriculum. Thank you, Badinka.
You're welcome. You're welcome. We're still trying to see if Prof. Tunkara is around. If she is not, I will move to another question. It says, considering the current standard of medicine and healthcare in the country, especially the poor standard of laboratories across all the regions with regards to microbiological analysis, could this empirism, this is the empirical data we found, could this be observed from the physician due to inability of laboratories, that is resource limited, to offer a clear microbiological results, or is it at the species level of identification of causative agents, or probably depicting the antimicrobial susceptibility testing profile? So this is a question that the person
Sorry,
sent.
can you repeat the question again?
Yes, it's a pregnant question. Of course, it's trying to pull out three factors of which is more corresponding to our findings, meaning perhaps is it the antimicrobial susceptibility profile which is missing in the labs, or the expertise, that is the species level of identification, the expertise. So let's say resource, expertise, and of course, okay, let's put it in two ways.
Okay,
is it
Doc,
because of due to resource or experts?
yes, Doc,
which of the two?
Can you hear me? I believe I can clarify the questions. I'm the one that pasted it there.
That one. This is not a PhD lecture hall.
Okay,
just
go ahead.
in simple terms, my question is, so we've said previously that doctors are prescribing antibiotics even on non-bacterial infection. So it's probably an attitude problem. So, but I'm asking now, is it possible? So I was a lab scientist. I work in several labs in the country. The microbiology laboratories are very under-equipped, sometimes not even to the point where they can be able to perform all the standard assays. So I'm saying, could the problem be also in the structural deficits in the fact that the laboratories are not able to perform this analysis to be able to identify the causative agent or even their AST profiles, and that doctors are not able to get this information from the lab. Like, could this be the problem as to why we are also seeing clinicians just engaging or indulging in empirism?
Okay, I got it. First and foremost, the laboratory, if we're talking about Edward Francis, we have well-trained human resources. The problem is, if you have the most trained and or highly trained personnel, but they are not given the right or adequate material to work with, is tantamount to zero. Because I keep on saying that when you isolate an organism, if it is, let's say, streptococcus, you need to know which of the streptococcus it is. It is Streptococcus agalactiae. Is it Streptococcus pyogenes? It is Streptococcus pneumoniae. It is the viridans. So you need to know. Don't say Streptococcus and end it with species. I always say each of these organisms, they have their names and surnames. So many laboratories in this country, microbiology laboratories, they are limited. It's not because they don't have the human resources. They do, but they don't have the resources to enable them to characterize the organism up to the species level. That's the fact. It is sad that when we come to tackling infectious diseases, the laboratories are not well equipped. They are not well equipped. They are, in terms of equipment, or maybe they will have equipment, but they don't have reagents. That's a fact. I can be quoted anywhere. It's a fact. And this is something that the Ministry of Health, the hospitals, they need to work on if we want to tackle AMR. That's the bottom line. Now, coming to the doctors or the prescribers, let me not say the doctors, the prescribers. Some of them, they know the constraints of the laboratories, so they rather do empirical therapy than targeted therapy. But that is costing the patient. Because if the empirical therapy fails, you will resort to try to go back to the lab for targeted therapy. And that is costly in terms of hospital stay, in terms of out-of-pocket expenses. And who knows, maybe the patient might end up being part of the mortality statistic. So this is a problem. It is a problem, and we definitely need collaborative effort to tackle AMR, both in terms of strengthening our health systems, raising awareness, training, as well as providing the necessary reagents and consumables that we need to work and produce local data for policy decision making. I think Ignatius' hand is up.
Yes.
Thank you. Thank you. I'm unmuted now. I was muted. That's why I could not talk.
Okay.
God save the Queen. You're welcome.
God save the Queen. I'm very happy and proud today. My Toma, all of you touch Gayahbi. Talk about the healthcare provider, the attitude, the way we prescribe, even our knowledge. You made mention about the necessity to include AMR in our curricula, and we are pushing that. You've said it. We are the healthcare providers, including the nurses, the doctors, the lab technicians, the pharmacists, so they appreciate the importance. Most of the time we teach it, but sparingly, like when you're talking about when you give it antibiotics, this is the way you give it, otherwise they can be resistant, but we don't emphasize it. But if it is a model of its own or a cause of its own, then you can have more opportunity to delve in it and talk about the strategies so that they can know more about AMR, because it is really an issue. And people are asking about why some of the clinicians prescribing are prescribing antibiotics for non-infectious diseases. Yes, sometimes when you are there, you can understand the way that they will explain because of the environment, the poor infection control in some of our healthcare settings. Looking at the immune status of the individual, sometimes when they have particular diseases, because you are afraid of them catching an infection, you want to cover them. Because of those reasons, that's why they use antibiotics as prophylaxis, even though it may not be the best answer because it increases the risk of AMR. But those are some of the reasons why you will see that some of the non-infectious diseases, they tend to give them antibiotics. Like, for example, dog bites. Dog bite, we don't expect that there should be an antibiotic. It should be anti-rabies. But they are afraid that if that dog bite is not managed properly, with that bite wound, there can be infection, and especially if it is too deep, and that can be catastrophic. So that's why sometimes you see them bringing in antibiotics. So during our intervention, we were also trying to improve on attitude towards infection control, because many of the antibiotics that we are prescribing infection control can solve that. Because even if you prescribe correctly and people are repeatedly infected, there can be resistance. So that is for the healthcare provider. You made mention about the lab. I cannot go back to it, the issues down there, but also in our population, our community, the way they use antibiotics is really an issue. You will see that sometimes you go to a health facility, they prescribe drug for you, you take it for 1 day, 2 days, you feel that you are not that much better, you move to another hospital. Instead of going back to the first prescriber, you move to another prescriber. And there is tendency that you can receive different form of antibiotics, which they may not even complete the dosages. That's at community level, and sharing of antibiotics among family members, among friends is also happening. Also, people starting antibiotics for some time, they see that they have improved and they stop it. That's the antimicrobial. So there are a lot of things that is in our table, and we are all stakeholders. We all should work together to fight antimicrobial. As I've mentioned, it has multifaceted causes, and all these causes need to be targeted in order to fight AMR. Thank you so much. I'm really so happy that I'm part of this. Well done, well done. I'm happy.
Thank you.
Thank you so much.
Thank you, Prof. Tunkara, and thank you, Dr. Bah, for the wonderful presentation. Thank you, Gassam, for organizing. Brilliant.
Badinka,
Yes,
before we round up, I want to take this opportunity to thank the team, because I cannot do a presentation and just leave it at that. We have a great team, and I just want to say, okay, what happened to my slide? I just want to say thank you very much to the team. From the National AMR Task Force, we have Haruna Jallo, Njundu, Dr. Njundu, Haruna Seidi, Dr. Haruna Seidi from Serakunda, and Abu Kebe, and I cannot remember all of them, but I just want to say thank you very much for their contribution in scaling up antimicrobial stewardship program in other health facilities. But for the Pfizer team, I just want to say thank you very much for my team. And because of the work that we did at Edward Francis Small, and we did it really well, that was the reason why they made us spearhead the roll out of the antimicrobial stewardship program in other hospitals. I could not have done it without all of you guys. My Toma, Prof. Haddy Tunkaraba, Baba Kunta Fofana, Dr. Safia Tudabo, my chat, Dr. Usman Bajinka, and then this is the whole Pfizer team. We have Dr. Abdullah Bajan, who's very, very instrumental in the Pfizer research team. Abu Bakar Bah, also, our chat of the team. And we have Eliza Baba, also, who is also part of the team. In general, this picture is the whole Pfizer research team of Edward Francis Small Teaching Hospital. And I say thank you very much to all of you. And we continue to work and evaluate what we have started in Edward Francis, and making sure that by the time we say 2030, we'll see reduction in antimicrobial resistance in our country. On that note, I say thank you very much for giving me the platform, and I hope I've done justice to the topic. And thank you.
Indeed,
Over.
indeed, you did justice to the topic. Brilliant.